Thank you very much, sir. Without any further delay, I know that this is odd time to start at evening, but I think this is comfortable for many. So without any further delay, I would like to request young and emerging arthroscopy surgeon, Dr. SUSHIL THAPA, who comes from Chitwan, a very good friend of mine, to start his presentation, please. SUSHIL. In the meantime, I would like to request everyone to keep themselves muted and the video turned off, except the presenter who is presenting. And would also request Dr. Nirav Kayastha to just admit all the people who are coming on the, entering into the discussion, and humbly request everyone to put any kind of question into the chat box, which can be, further discussed and taken up for panel discussion time. Don't hesitate to ask any type of question. Thank you very much, Sushil. You can start your presentation.
Thank you very much, Amit sir, and the entire ASON team. Thank you, Amit sir, again for such a kind and inspiring words on me. My talk is on rotator cuff surgical anatomy. The surgical anatomy is quite a new topic to me. We were quite familiar with the pure anatomy, but since very few surgeries are done on rotator cuff tears and other pathologies, it's quite a new topic. So I'm trying to simplify this as much as possible to my knowledge. This is the attachment of the rotator cuff muscles. It actually comprises of supraspinatus, infraspinatus, teres minor, and subscapularis muscle. The axons, their respective axons have been mentioned here. Supraspinatus abducts our arm, while infraspinatus externally rotates in adducted arm, and teres minor in external rotation in abduction, while subscapularis, this internally rotates our arm. And the subscapularis attaches, this is the anterior view of the humerus, and this attaches to the lesser tubercle of the humerus. And this is intertubercular sulcus. And it's very important to note that this subscapularis muscle is medial to the intertubercular sulcus, through which the biceps tendon passes. While this is the greater tuberosity, and along the lateral aspect of the greater tuberosity, supraspinatus takes its attachment, and there is a central facet where infraspinatus attaches, and teres minor downwards, inferior to the infraspinatus attachment. This is the posterior view of the rotator cuff muscles. And these axons are exploited. These are used in examination of the respective muscles. So we abduct to test the supraspinatus muscle. We externally rotate the adducted arm to test the infraspinatus muscle, but we abduct the arm at 90 degrees and externally rotate to test the teres minor test. And we internally rotate in what is popularly called the press belly test to test for the subscapularis muscle. Let me set light briefly on each muscles. The supraspinatus muscle, this takes its origin from the supraspinatus fossa, and this goes in between the coracoacromial space, right up to the greater tuberosity. And this is the tendinous portion. This is the tendinous portion of the supraspinatus, and this is the muscular portion. So just as it approaches the glenoid cavity, this becomes tendon, and this tendinous portion blends with the capsule. So it's difficult to differentiate between the capsule and the tendon as it blends when it goes near the attachment. And this is the deltoid muscle. This lies superficial to the subacromial bursa. This is subacromial bursa, shown in green color. Sometimes we may get confused with the supraspinatus tendon. So, and we may operate on the subacromial bursa instead of the supraspinatus tendon. So there are a few tips to identify the subacromial bursa during surgery. When we abduct our arm, this retracts quite underneath this acromion process. And this is type of cystic in nature. It contains fluid, so it should be well differentiated from the supraspinatus tendon. And this is the axillary pause. This is quite redundant, and this is present inferiorly. So supraspinatus muscle, this is the sagittal section MRI of the rotator cuff muscles. This is supraspinatus. This is the subscapularis muscle. And this is the fatty infiltration. So certain amount of fat is present superficial to the superior to this supraspinatus muscle. And the amount of fat that's present prognosticates the rotator cuff tear. So if it's more than 50%, even if we repair the tear, the prognosis is going to be poor. So this amount of fat carries special significance, and that can be read or quantified in MRI sagittal section. And another important factor here is this is the retracted muscle, and we measure the retracted supraspinatus muscle in MRI. We can measure well. We take the distance from this point. This is a greater tuberosity, and this is the retracted portion. And the more the retraction, poor is the prognosis. This is another important factor to consider in supraspinatus muscle. And this is the supraspinatus muscle. This is the fusiform belly of the muscle, and it goes all the way up to the greater tuberosity attachment. And this is the fat plane seen in MRI. We may not see this in all the films, but if we keep scrolling, this fat plane separates the supraspinatus from the infraspinatus muscle. So in MRI, it's important to differentiate in between supraspinatus and infraspinatus muscle. This is the fat plane. And another important consideration is in case of torn rotator cuff muscles, the humerus migrates proximally. That's because basically the function of the rotator cuff is to pull this humeral head against the glenoid cavity and thereby stabilize it. But in case of rotator cuff tear, it's the deltoid that becomes more active, and this causes the upward pull of the humerus, and the factor that pulls this towards the glenoid is lost. So it causes glenohumeral disturbance in the glenohumeral biomechanics, thereby leading to the OA changes of the glenohumeral joint, and the subacromial space reduces. It causes pain because of these conditions, these causes. So as we abduct our arm, this subacromial bursa retracts inside the subacromial space. And in abduction, with alternate external and internal rotation, this supraspinatus muscle, this impinges against the acromion process and the coracoacromial ligament. So because of alternate internal and external rotation, it keeps on rubbing against this acromion process and the coracoacromial ligament. So because of this, it undergoes inflammation, congestion, and pain, which is commonly called the impingement syndrome. And so examinations are also based on the Hawkins kinetic test, Yob's test, empty can test. In these tests, we internally rotate we ask the patient to internally rotate the arm so that whether or not the supraspinatus tendon gets rubbed against this acromion process is examined. And this condition is called impingement syndrome. So the occupations where the patients, where the individuals have to repeatedly, alternately, externally and internally rotate their arm, like the barbers or the floor cleaners or the wipers who keep cleaning the window very frequently, they have this problem. This is called impingement position. Subscapular muscle is another important muscle. It takes its attachment from the anterior portion of the scapula and takes its insertion into the lesser tubercle. And this muscle, like supraspinatus, it becomes tendinous and it blends with the capsule as it reaches the glenoid cavity. And the quadrangular space, this is the quadrangular space. This is formed by the triceps, teres major, humerus, and the actually teres minor. But when it comes to the surgical significance, teres minor is beneath the subscapularis muscle. So let's concentrate here on subscapular muscle. This axillary knob goes along the inferior border of the subscapularis muscle and then winds around posteriorly to come to the, and then supplies the deltoid muscle. So when you are operating on the subscap muscles, we make incision on this junction of the 1/3, 2/3, or on the middle part of the subscapularis muscle, and we take very careful attention not to injure the axillary nerve, which is present on the inferior border of the subscapularis muscle. And even during arthroscopic surgery, when you are operating on the conditions like the Bankart repair, we avoid this portion to prevent injury to the axillary nerve. And there is a bursa that separates the subscapularis muscle from the underlying scapula. And this bursa has an opening into the joint. So this bursa can be an important landmark to separate the subscap from the underlying overlying subscap. And if you look at the axial view, this is the supraspinatus muscle, and this is subscapularis muscle. And this is the part where the biceps tendon passes. This is greater tuberosity. And this tendinous portion always blends with the capsule. So it has some surgical significance. When you want to lengthen this tendon and reattach this to their original insertion, we may need to sacrifice this capsule at the glandule attachment. So this axial view has its own significance. These are the different muscles. When you look at the muscles from the superior view in arthroscopic surgery or even in open surgeries, these are the muscle arrangement: subscapularis, lesser tuberosity, and this is the supraspinatus. This is the largest portion, and it is the most common of the muscles to get torn out of the rotator cuff muscles. And this is the infraspinatus muscles. And this is the torn portion that has been shown. And the fascial attachment of the rotator cuff is present. And this fascia goes all the way from the rotator cuff up to the base of the coracoid process via the coracohumeral ligament. And this is again very important while we are mobilizing the rotator cuff while we are going to repair this muscle. And surgically, it may be difficult to differentiate between supraspinatus and infraspinatus muscle. A capsule is, again, it has the subscapularis bursa. It looks like an opening in the capsule on the anterior portion. The rotator cuff is absent in the axillary pulse. So this is the least supported portion of the capsule, but the rest of the capsular portions are supported very well by the rotator cuff muscles. And another important ligament here is coracohumeral ligament, and this prevents upward migration, thereby increasing the stability of the shoulder muscle. So this coracohumeral ligament should be prevented in rotator cuff surgeries and other surgeries around the shoulder joint. This is subacromial bursa, and this is the coracoacromial ligament that fans out to the acromial process from the base of the coracoid process. And biceps tendon, this is the synovial sheath of the biceps tendon, which we look for the loose bodies lodgement inside this biceps tendon. And this is also involved in the impingement syndrome. The acromial process is another important consideration in the anatomy of the rotator cuff muscles. This may be flat, curved, and hooked type. In case of hooked type, this is hooked all the way inferiorly. So the coracoacromial space is very narrowed. And this hooked type of acromial process has larger incidence of the rotator cuff tear. That is why, while we are operating on the rotator cuff tear or impingement syndrome, the decompression, that is acromioplasty, combined with repair, has shown better results. So acromioplasty, or the surgery on the acromion, has to be considered while we are operating on the rotator cuff pathologies. So how to mobilize the rotator cuff when it's torn and retracted way towards the coracoid process? So this is the torn rotator cuff muscles, and this is there is a fascial attachments on the superficial aspect of the rotator cuff all the way up to the base of the coracoid process via coracohumeral ligament. And when this fascia is incised here, then we can pull this rotator cuff for mobilization of the rotator cuff so that we can take it closer to the greater tuberosity for reattachment of the torn rotator cuff. But it should be remembered that this the coracohumeral ligament should be preserved, which is attached to the lateral portion of the greater tuberosity. This is the incision of the fascia that helps us mobilize the rotator cuff. So another important consideration is this is the tendinous portion. This is the supraspinatus and the subscapularis portion. We incise this capsule at the glenoid rim, both anteriorly, both all around, so that especially where these muscles are present, so that these muscles can be taken towards the tuberosities for repair of the rotator cuff muscle. This is how it looks like. This is the arthroscopic anatomy, and this is the subscapularis tendon, and this is the shoulder when viewed from the posterior portal. This is the head of the humerus, and this is the biceps tendon. The synovium looks congested here, and this is the anterior part of the shoulder joint. So this is the head of the humerus. If we take the scope proximally, this is the biceps tendon, and this is the recess of the biceps tendon. And as we go towards the tuberosity, this is the tuberosity lateral portion where the rotator cuff gets, where the rotator cuff takes its attachment on the lateral portion. This is the intra-articular part. Actually, we see the capsule, and the overlying structure is actually the rotator cuff. But we see capsule here. To see the rotator cuff, we can visualize from the lateral portal, so that the overlying rotator cuff muscle can be visualized and operated upon. So this is the brief talk on the rotator cuff surgical anatomy. Thank you very much.
Thank you, Sushil. That was wonderful talk as always. So if any questions, I would like to request all the participants to post it in the chat box. We will take all those questions during panel discussion. So I think without any further delay, can we proceed to next talk? Next talk is by Professor Amit Joshi, who needs no introduction. I think he is the one who does the most rotator cuff surgeries in Nepal. So let's hear from horse's mouth himself how to approach this of patient with.
Thank you very much, BIBEK. It's really a privilege and honor to share some of our experience and some of the approaches that we utilize on rotator cuff tears. So today I'm going to talk on. Just a moment, please. Just hold on, there is a small hitch. So is my slide visible now?
Yes, sir, it's visible and you are audible.
Okay, so let us talk about how to approach the rotator cuff tears. I will basically touch upon the very basic of rotator cuff tear, right from its diagnosis to treatment, and little bit I'll talk about most commonly asked question by our younger colleagues. This is taken from one American study, which clearly shows that if you age, so you see above 60, and then above 60, and when you go to 80 years, almost 80% of these patients will have a rotator cuff tear. So rotator cuff tear in Western populations are more common in above 60 years of age. So if we see another study, which is this picture was taken from someone Indian study, which says again the majority of the rotator cuff tear are between 60 to 80 years. So what should be in our Nepal context? Although we do not have a published paper, but we presume that if it is in India, it should be something similar to ours. So what I did was I analyzed out 39 cases of last 1 year. And to my surprise, if you see, the common incidence of rotator cuff tear was mainly at the age of 40 to 60 years. So it clearly says that probably we are treating more younger people than the older people. So this may be because of two reasons, basically. Number one, the older people live with their disability, and the older people are probably neglected. So the grandfathers, all these people are, maybe they are neglected, and they say that they consider all these problems as a part of their aging process. Or the another aspect is, are we as a physician missing the rotator cuff or underdiagnosing the rotator cuff? That has to be, taken into consideration. So if you see the division of those 39 cases of our past 1 year experience, so out of these 39 cases, only 7 were referred to us with the diagnosis of rotator cuff tear. So 80%, for more than 80% of the patient, the primary diagnosis was frozen shoulder or impingement syndrome. So what this table clearly says, that there is lack of awareness amongst us as well, that we diagnose these rotator cuff tear as a frozen shoulder most of the time, and sometimes as a impingement syndrome. So another further analysis of these 39 cases, though these are very small, case series, but what is remarkable is average delay of diagnosis was about 14 months, and all of these patients were tried and tested for physiotherapy. So we diagnose them as a frozen shoulder, and then we send them for physiotherapy. And only 18% of the patient came with the diagnosis of rotator cuff tear. So this was the current scenario of ours. So which clearly indicates that probably there is a great, lack of awareness amongst ourselves also, amongst the clinician as well. That is why this presentation is basically hovers around raising the basic awareness or the basic information that is required for the clinician. So my presentation will basically focus on 3 issues: how to diagnose the rotator cuff tear. If we have diagnosed, then what will be the treatment of the rotator cuff tear? When to suggest your patient a surgical intervention, or when to suggest the patient will do good with the conservative management. And finally, I have few slides on basic questions that were asked by my younger colleagues over the WhatsApp or any other social medias. So coming to the diagnosis, symptomatology is one of the most important things that we have to look into. And 90% of the patient with rotator cuff tear present pain, 60% present with stiffness. And because of this 60% stiffness of these rotator cuff tear, we tend to diagnose them as a frozen shoulder. And irony is, only 11% of these patients with rotator cuff tear, they present as a weakness of the shoulder. So pain is the primary symptom of these rotator cuff tear, followed by stiffness. And the last one, but not the least, is the weakness. So if you see the pain, it is not specific for the rotator cuff tear. And most of the time, this patient complain of pain on the elbow, on the arm, forearm, and even on the neck side. So there are several other overlapping conditions which can mimic the rotator cuff tear, or even the rotator cuff tear, they do not present as a specific pain symptom on a specific reason. So based upon various ligaments or the tendon which has been involved in the rotator cuff, the pain may differ right from intensity to its location. That is why only based upon pain, it is very difficult to diagnose your patient as a rotator cuff tear. Coming to the frozen shoulder, this is a very popular slide. I am sure that most of us, we know how to differentiate between frozen shoulder and the rotator cuff. But I would again like to emphasize, because Among the 39 referred cases that I have gone through over last 1 year, I found that basic examination was lacking. So just to emphasize on that, in frozen shoulder, both active and passive range of motions are limited. Whereas in rotator cuff, active may be limited, but passive is possible. So there is a disparity, or there is a discoordination between the active and passive motion in rotator cuff. Whereas in frozen shoulder, both the active and the passive movement will be the same. So this is a very this is a very small video. If you can see that what I am doing, a very simple test. In this place, patient is doing active, and he says that he's not able to abduct his shoulder further than that. Then I assist and do a passive range of motion, and this patient can have a full passive range of motion. So the combination of active and the passive range of motion is very clearly indicative of either it is a frozen shoulder or it is a rotor cuff tear. And this applies not only to the abduction, but this applies to other movement as well. Say it is an internal rotation, external rotation, or any of the rotation. I would just like to give one slide on the impingement test, because largely this impingement test is underutilized for the diagnosis, basically for the differentiation of impingement versus the rotor cuff tear. I'll not go into detail of this because I presume that most of us we know this, but what we have been doing at this moment is we are doing a therapeutic injection modalities rather than the diagnostic modalities. So impingement test, that is injection of lidocaine or xylocaine under the subacromial space, this is called impingement test, is very sensitive tool for the diagnosis of rotor cuff tear, and it will differentiate between the impingement and the rotor cuff tear. And probably I would suggest everyone to more utilize this. And what my current practice is, if some patient have a severe pain and we are not able to do a thorough clinical examination, I give a shot of a lidocaine in the subacromial space, wait for 15 minutes, the pain will be less, and once the pain will be less, you can actually assess the muscle strength, and you can actually test the power of all the rotor cuff muscle. So probably this is underutilized. I do not mean to say that each and every patient has to go through this, but it has to be judicially used for the examination purpose as well. So as a clinician, I'm not going to teach you all the clinical tests, but we must do 4 tests to examine the 4 rotor cuff muscle. For supraspinatus, I'll suggest IMTICAN and full can test. For infra, it is external rotation lag sign. For teres minor, hornblower sign, and for the subscapularis, these are the lift-off tests. So these are the basic tests which we must do in a patient, in each and every patient who comes to us with a pain on the shoulder joint, irrespective of what may be the condition. But as I say, 60% of the rotor cuff patient, they come with the stiffness of the shoulder. And if you know all these movements, all these tests, special tests requires fair degree of movement of the shoulder. So if joint is stiff, we must check power of these muscles. And to check the power of these muscles, the shoulder has to be pain-free, either by physiotherapy, you have made the shoulder pain-free, or you have given a subacromial injection so that the patient is experiencing less pain. So that is how you can actually assess. So if there is a good range of motion, perform the special test. If the range of motions are limited, you better test the power of that muscle in whatever position you can do. So this is the way by which you can diagnose your rotor cuff. This is just, I'll go quickly how to check the power of the supraspinatus. The shoulder is adducted and the initiation of the adduction will be done by supraspinatus, and then you are checking the power on both the side. And it's so easy to understand that one side is weaker than the other side, which is very simple test. So this is a empty and the full can test. Flexion on the plane of scapula, which is little bit of 10 to 15 degree of abduction. This is empty can test. You are completely internally rotating, and then you do a full can test in which you supinate the forearm. So difference in the pain, most of the patient will have pain in empty can, and the pain reduces in the full can test, which is classic demonstration of the involvement of the supraspinatus tendon. So coming to the infraspinatus, as Sushil was also saying, it does external rotation in adduction. So you do external rotation in adduction. You check the power. You can do one by one, or you can go to one part first and then come to the other involved shoulder second. So check the power on the normal side, then you come to the check the power on the pathological side. So this is done in this is the checking of the power. And this is what infraspinatus special test, which is known as the external rotation lag sign. I'll show you, demonstrate you this very interesting case. You completely extend rotate the shoulder with adducted shoulder and the elbow at 90 degree. And then you ask the patient to maintain the full external rotation. So which he was able to do on the left side, but you see now he's not able to maintain that external rotation. See, I'm again doing it, so not able to maintain that. This is a very simple test which will tell us that there is a complete rupture of the infraspinatus tendon. So to do a hornblower sign, this is a very simple test. Its sensitivity is really questioned, but this is a very special test which can be done. So do an external rotation with 90 degree position of shoulder and elbow, and ask the patient to maintain that external rotation. See, this he's not able to maintain that external rotation, and the shoulder is coming into the internal rotation, which is known as a hornblower sign. In the same position, you can test the power also. Tell the patient to externally rotate, and you resist, that will test the power of the teres minor. So this is a lift-off test. Sushil was saying a belly press sign, but I do a lift-off test. There are several limitations, but this is very easy test. If you can see that, you just need your hand has to be, the dorsum of your hand has to be on the back of your lumbar spine, and then you pull it outwards and leave it there. So ask the patient to maintain the pulled out position or lifted off position. Most of the patient will not be able to. A patient with subscapularis tear will not be able to do this lift off test. So this is a very simple test. If this is not possible, you can do a belly press sign or the bear hug test you can. So coming to the summary of this test, empty can and full can test is very sensitive, but this is not specific for supraspinatus and infraspinatus. External rotation lag sign for infraspinatus is very sensitive and specific. Hornblower sign, as I said, this is very less sensitive, but it is very specific, and lift-off test is again 50-50 sensitivity and the specificity. But these tests are, our OPD day-to-day tests that each and every patient has to be has to go through these tests so that we don't miss this. Ultrasonography, if you go to literature, you'll find out everywhere as an ultrasonography, and it is called as a very sensitive, and it has several advantages that it is a dynamic. You can do an intervention, injection, USG guided, and it is a very dynamic test. But unfortunately, this is very much observer dependent. So it requires a great deal of experience. Unfortunately, in Nepal, we do not have such dedicated musculoskeletal radiologists who could identify a small tear like this. Although USG is at this moment office examination for most of the shoulder pain, but in Nepal, we are not able to utilize it to its extent. MRI is the gold standard, not only for the diagnosis of tear, but status of a muscular degeneration and other associated intra-articular condition can be diagnosed with the MRI scan. So to summarize, summary of the diagnosis is clinical examination is very, very important. No patient with shoulder pain should go out of your clinic without examining the rotator cuff, both the power and the special test of 4 rotator cuff tears. USG can be utilized, and then we have the responsibility to train our people. This is cost effective, this is cheap, this is non-invasive, and has all the advantages that a poor country like ours should utilize. Unfortunately, it has so many limitations. We are not able to do it. That is why MRI still remains the gold standard. So the clinical examination and the other investigation increases the diagnostic accuracy. So coming to the second part of my presentation, how to treat the rotor cuff. We all know that a rotor cuff can be treated conservatively. It can be treated operatively, and you can be watchful and follow the patient and decide based upon the follow-up progression of the tear. So how to decide which is best for my patient is the most important question for clinician like us. So to know how to decide, we must understand that there are two types of rotor cuff tear. One is a full thickness and the other one is a partial thickness. Most of the time, the radiologist reports that there is a partial tear of supraspinatus or partial tear of subscapularis, and then we don't know what to do because there is rotor cuff tear, but it is partial. When there is a full thickness tear, most of the time we know that this is a full thickness tear. Probably he may need a surgical approach to fix this full thickness tear, but there are a lot of confusion regarding the partial tear. I'll talk on that, but the full thickness, for full thickness tear, Allman has given a classification based upon the size of the tear, so which is small size, less than 1 centimeter, medium, large, and the massive. So if the tear expands 5 centimeter in any of the direction, they are called as a massive tear. This is the basic classification that is used. So this is the basic algorithm that I use for treating my rotor cuff patient, and most of the literature agree to this protocol. So first of all, when you identify a rotor cuff tear, you just think about either it is a acute or it is a chronic. Usually there are multiple terms used for acute. Acute are also known as traumatic. Chronic are also known as degenerative. So if it is an acute tear, whatever size it is, either it is a small, medium, large, or massive, if it is an acute tear, then probably the choice of treatment of this patient will be a rotor cuff repair. So if a patient of 60-year-old comes to you with a history of fall, you have examined all the muscles, there are weaknesses of most of the muscles, and then MRI shows this is a tear. So this is an acute traumatic tear. Most of the time, irrespective of size and other thing, these traumatic tears has to be repaired surgically. Question comes when there is a degenerative tear. So you meticulously ask the patient, either the patient has a trauma, he was not having a trauma. Sometimes the trauma can be very trivial, it may confuse you. That is why the history of trauma is very, very important when you talk about rotor cuff tear. So if it is a atraumatic or degenerative or chronic tear, then you further investigate and identify either it is a medium-sized tear, small-sized tear, or large, or even a massive tear. So if it is a medium-sized tear, 1 to 3 centimeter, medium-sized tear, so they tend to progress. That is why you have to do a surgical intervention for those patients like rotor cuff repair. If the tear is small or if the tear is very large, then your treatment depends upon the symptom of the patient. Even if your tear is small, but the patient is very much symptomatic, the muscle is very weak, there is a wasting of supra and infraspinatus, probably even a small tear require a surgery. Same applies to the large tear. So if it is a small and large tear, then you have to see the symptoms. If there is a minimal symptom, then you try a conservative treatment. If there is a symptom is very severe and the patient is not responding to your conservative treatment, then you decide for surgical treatment of those patients. So this is the very basic algorithm for the treatment of full thickness rotor cuff tear. What about partial thickness rotor cuff tear? So there are two types of partial thickness. One is the articular side, the other one is the bursal side. So both the sides, if it is a partial articular, it is called as a pasta lesion. If it is a bursal side, then it is called as a reverse pasta lesion or acromial or a bursal tear. So both these tears are graded into grade 1, grade 2, and grade 3 based upon the thickness. So grade 1 is less than 1/4, which is usually less than 3 millimeter. Grade 2 is 3 to 6 millimeter. Grade 3 is more than 6 millimeter. So if you get a report, if your radiologist reports that it is a partial tear, if you do not have a tool to measure how much thickness of the rotor cuff is torn, you send back your patient to the radiologist and asks to measure the thickness of the whole thickness of the tear, whole thickness of the rotor cuff and how much is torn. So based upon that, you can grade less than 25, 25 to 50, and more than 50. So based upon that, again, you can decide what to do with the partial tear. So if it is a pasta or it is a reverse pasta. So if it is a pasta, you have to be, more conservative. So even grade 1 and grade 2 can be treated conservatively. Grade 3 only has to be operative. If it is a reverse pasta, which is a bursal side tear, so bursal side tear has a more propensity to grow, excuse me, more propensity to turn into a full thickness tear. So based upon, again, symptom, age of the patient, functional requirement, even grade 2 pasta, reverse pasta tear or the bursal side tear has to undergo a surgical treatment. So this is a basic algorithm, and probably I presume that this will very clearly elaborate how to tackle a full thickness tear and how to tackle a partial thickness tear. So coming to the very questions, I'm privileged that my younger colleague, they trust me and they keep on asking me certain questions in the WhatsApp, Telegram, and even in the BIBEK. So I have collected some of the very frequently asked questions. So one of the very important thing is how does the age influence the treatment? So if we see that age is very, very important, the high incidence of rotator cuff tear in the elderly people, high chance of repair failure. So when you are talking about repair of the elderly patient, there is a high chance of repair failure as well. An irreparable rotator cuff tear in elderly, you have to do some other treatment. And if you are not planning to repair in the younger patient, then you have to do. So age bears a very heavy, importance in case of rotator cuff tear. So which technique will be better, arthroscopy versus open technique? So both are good based upon what you are exposed to. If you identify a good case for surgery, a open or a mini open gives an equally good result. But there are several advantages of arthroscopy. I'll not go into detail. But if you are not exposed to arthroscopy, this is one of the very difficult surgical procedure to perform arthroscopically. If you are exposed to open, you can continue with your open technique, and both of them have shown good result. So if it is a rotator cuff tear, which is basically diagnosed on MRI, is there any role of X-ray in rotator cuff tear? This is a very important question I have encountered. And then I would like to say that one word, that X-ray is very, very important because you can measure several things. One is a acromial index, you can measure interval. Then you can also see on the scapular Y view, the Bigliani's type of acromion, which Sushil was trying to say. But what is important is in X-ray, you can classify your rotator cuff tear by Hamada's classification. And if you use this Hamada classification, it is very easy for you to decide either this patient requires a surgery or he's not going to do good with the surgery. So any case above Hamada grade 3, grade 1 and grade 2 can be managed still operatively by rotator cuff repair, whereas any Hamada grade 3, 4 and 5 will not do good with the rotator cuff repair. So you have to identify some other alternative for the treatment. So just to decide what treatment will be suitable for this patient, probably Hamada classification is very, very important. Do we need MRI for all rotator cuff tear? Yeah, absolutely yes. It is not only to identify what is the extent of the tear, but either your repair is going to work or not. It is also important to do an MRI. So that will indirectly tell us the cuff quality. So I'll not go into detail of this. The Gutalier grading has to be done of the fatty infiltration. And most of the research, they say that if there is a stage 3-4 Gutalier fatty infiltration, there is a poor outcome. Even if you are able to repair the rotator cuff, since most of the muscles are replaced by fat, your functional outcome will not be good. And again, MRI is important to classify based upon the its retraction, the PATE classification, and if it is a stage 3 and it is degenerative, probably the poor anatomic repair. So anatomic repair will not be possible. That is why X-ray, MRI, all the things are very, very important. Another very important thing, I'll not go into this, probably BIBEK will touch upon this, the role of steroid in rotator cuff. If operative plan, please do not give steroid. So you thoroughly assess your patient, and if you feel that this patient requires a surgery, do not give steroid, because if steroid is given, we have to delay the surgery for 3 months, which may be crucial in decision making. And after 3 months, our rotator cuff may not be repairable. So that is why if surgery is required, please do not give steroid. But if you are sure that this patient is not going to get surgery in next 6 months or 1 year time, probably steroid is a very good choice for the treatment of these particular patients. So with this, I'd like to conclude by saying that diagnosis of rotator cuff is difficult, and it requires a high degree of suspicion and the methodological examination of a patient. Do not forget to test at least one test for each rotator cuff tear. That dramatically increases the detection of rotator cuff tear. MRI remains the gold standard. Gone those days when we used to say that, oh, it is very costly. एकदम महँगो छ, अलिकति फिजियो गरेर हेरौँ, भएन भने MRI गरौँला. It is not that time. If you are sued, not only for being delaying in diagnosis, not by not doing an MRI, we are going into the problem. That is why do not hesitate. If you find out there are enough clinical feature indicating a rotator cuff tear, do not hesitate to do an MRI. Optimal treatment modality depends upon the various factors that I have discussed. And not all patients require a surgical treatment. Majority can still be treated conservatively, but we have to know that which patient will go for conservative treatment and which patient will go for a surgical treatment. For that, we need a thorough assessment of that patient, right from history, clinical examination, and investigation. With this, I'd like to thank everyone for patience listening, and thank Arthroscopy Society of Nepal for giving me opportunity to present my view on rotator cuff tear. Thank you very much.
Thank you, Amit sir. That was the wonderful talk as always. So the message was loud and clear. So though the rotator cuff tear is difficult to diagnose, it is not impossible. We have to be very vigilant. Do MRI whenever you are in doubt. And many of these cuff tears can be managed conservatively. All cuff tears does not need surgery. So there is one question in chat box. I think I will take it just now. Sudeep sir has asked, can rotator cuff tear and frozen shoulder exist together? If yes, how to assess them clinically?
Thank you very much, sir. I think I have tried to cover this, your question in my presentation also. I said that 60% of rotator cuff tear, they have associated frozen shoulder. So 60% of rotator cuff tear have associated frozen shoulder. So it is difficult to assess rotator cuff when there is a frozen shoulder. So you have two ways of detecting rotator cuff tear in case of frozen shoulder. Number one, you do a rehab for some time, and then you reassess the patient when the pain is less. If the patient is not improving with the rehab in 1 or 2 weeks time, so what you can do is, rather than continuing the rehab, test the power of the muscle. So the power of the muscle can be tested without having any special test. So you can do a initiation of abduction. But what is important, again, I said that before checking the power, the shoulder has to be pain-free. If it is not pain-free by rehabilitation, give a subacromial injection, make the shoulder pain-free, then again re-examine your patient. Most of the time you'll be able to detect the rotator cuff tear.
Thank you, sir. That was a very important question. In fact, many of the patients with rotator cuff tear, mainly the partial tear patients, come with stiffness and the secondary frozen shoulder and rotator cuff tears overlap. So it's very difficult, and points have been very clearly answered by Amit sir. So Dr. Nirav has asked, sir, how important is it to have a patient full range of motion before embarking on cough repair?
I think this is a very important question Nirav has raised. So whenever possible before rotator cuff repair, you have to achieve a full range of motion. If it is not achievable, this doesn't mean that you cannot do a rotator cuff repair. So if you have a limited range of motion, there are two ways you can go ahead. Number one is you can do a gentle manipulation under anesthesia, because while doing rotator cuff tear, your patient is under anesthesia. Or else there is another school of thought which say that rather than doing a manipulation under anesthesia, you do a arthrolysis before doing your rotator cuff tear. So preferably you need a full range of motion. If it is not possible, it should not stop from going ahead with the rotator cuff repair, but either you do a manipulation under anesthesia or you do a arthrolysis. I think I have answered his question.
Yes, sir. So I see no more questions in chat box. So I think we can proceed with another part of our today's presentation, that is the panel discussion. So many of the topics which I thought I would cover in my panel discussion has already been covered by Sushil and Amit sir. So there will be many repetition. I think this is not repetition, this will be revision. As Amit sir, we have discussion about this, that many things would be repeated, and Amit sir told this would be revision. So main theme of ASON is to raise the awareness about the rotator cuff. I think we will be revising more. So I'll be sharing my screen. Hello and welcome all. I'm Dr. BIBEK Basukala. I work at AKB Center for Arthroscopy, Sports Injuries and Regenerative Medicine. Today I will be moderating this panel discussion. The topic of panel discussion is decision making in rotator cuff tear. So to discuss about this panel discuss on this topic, we have very experienced faculties with us: Professor ARJUN LAMICHANE, Professor AMIT JOSHI, Professor NABIN KARN, and Dr. Binod Shertan. So shoulder joint, as Amit sir and Sushil has already mentioned, is very enigmatic joint. The pain caused by shoulder can be one condition may mimic the other condition. Like these, there are so many conditions that can cause the shoulder joint. These are various intrinsic shoulder conditions that overlaps one another, and there are many conditions, the visceral conditions, that has referred pain towards the shoulder joint. So pain around the shoulder joint, this was a study where the pain mapping of common shoulder conditions were done, and with these pictures you can easily see that. I think we have to mute.
Okay, go ahead, Rajiv. I'll see whose pet is barking. I'll try to mute.
Okay.
Yes.
Okay. So there is this pain mapping shows that these multiple conditions has the common thing is the pain mapping is very similar. So this makes the condition even more difficult for diagnosis. So my first question is to Nabin sir. As Amit sir has already mentioned, this will be a repetition or revision, whatever we say. Many of our shoulder conditions, many of our rotator cuff tear, for many of us, the first diagnosis is always frozen shoulder. So my question is it the ultimate diagnosis or is it the ultimate misdiagnosis? Nabin sir.
See, earlier, whenever the shoulder condition comes with the pain and stiffness of the thing, almost invariably for the first diagnosis used to be frozen shoulder. as the knowledge also increases, we also become experienced. We keep on examining the other things. So now it is becoming the most of the time we are misdiagnosing the frozen shoulder. So some other conditions like the rotator cuff and things are more commoner than the frozen shoulder. So one has to be very particular while examining for this.
So my next question to you, Navin sir again. So what are the conditions that you now discover that which you would have diagnosed as a frozen shoulder in the past?
So one of the commonest one is the again rotator cuff tear, which was must have, as Amit was still already Amit said that the 60% the association frozen shoulder and rotator cuff. So it is almost mixed out of there, but just on the basis of pain on the shoulder basis, there are a few other things also we have to take into consideration regarding this degenerative changes in the cervical spine, suprascapular nerve impingement. These things also now coming together. So we have to also be vigilant enough to see for those cases also, which are earlier we used to diagnose just as a frozen shoulder.
Absolutely, sir. Points very well taken. So, frozen shoulder, every shoulder pain. My message is very loud and clear from my this slide. That every shoulder pain is not frozen shoulder. Never ever make frozen shoulder as a primary diagnosis, because frozen shoulder is primary frozen shoulder is diagnosis of exclusion. Once you have to exclude all other conditions, intrinsic and extrinsic conditions, which will be causing the shoulder pain. So if all those conditions are ruled out, only then you can label that shoulder as having a frozen shoulder. Otherwise, that patient may be having secondary frozen shoulder because of some other pathology. So always rethink before embarking a diagnosis of frozen shoulder. So, as we all know, one diagnosis will not fit all the shoulder conditions. So my question to Arjun sir, you see lots of patients of shoulder pain in your clinic. So what are the main complaints, sir? If you suspect a case of rotator cuff here, what are the main complaints of your patient?
Thank you, Bibek. Can you hear me?
Yes, sir. Loud and clear.
Okay. The most common complication of the complaint by the patient for the rotator cuff pathology is the pain.
Okay.
And in many patients, they do complain pain at night. Okay.
Mm-hmm.
And while attempting to abduct or lifting anything or doing any overhead activities, then they do complain of pain.
So
and if
what
there
is
is a clear,
yes, sorry, sir. Sorry, yes, sir. Please continue.
if there is a suspected rotator cuff tear or a clear rotator cuff tear, the patient may present with the features of rotator cuff when the frozen shoulder is Navin mentioned.
Okay, points very well taken. So I think as Amit sir has also mentioned and Arjun sir has just mentioned, pain is the most common symptom. Almost 90% of our patients with rotator cuff, we might think that rotator cuff is torn, patient will be presenting with weakness, but weakness is very uncommon symptom. Pain is very common symptom, and this makes us to misdiagnose a case of rotator cuff tear as frozen shoulder. So what percentage of your patients with rotator cuff tear presents as stiffness? So question to Arjun sir again.
I don't know exactly the percentage, but
Yes,
it is most of the time it is misdiagnosed. And
yes,
even we do also, before doing rotator cuff surgery, used to diagnose as a frozen shoulder. In the early stage of frozen shoulder or in a recovering stage of frozen shoulder, since the patient do come with a complaint for a long time.
Okay.
And so these days, I cannot say exactly pathology, but not so uncommon.
Okay. Binod sir, are you around? Hello? Binod? Okay, I think he is not around. So Amit sir, the question is, Arjun sir has mentioned the night pain and the pain while raising the arm to do something over it. So how specific is this symptom for rotator cuff tear?
Thank you, Bibek. This is unfortunately this is not specific. for any shoulder pathologies, for some reason, night pains are common. Say it is a primary frozen shoulder, the rotor cuff tear, the osteoarthritis, even for infection, even for inflammatory arthritis. For some reason, these night pains are very, very common. This has to do something with the circadian rhythm or something, I don't know. But night pains are common. Most of my patient usually, they come with pain. Pain is the first symptom, various types of pain. And the second is, I'm not able to lift my hand, or I'm not able to abduct my shoulder. That is the main complaint with which patient comes to me. The pain is not specific. Pain is not specific at all.
So have you seen some difference with your patients who you would diagnose later as partial tear after MRI, partial tear and complete tear? The complete tear patients have more weakness than pain, and partial tear patients have more pain than weakness, because the literature mentions just like this.
Yeah. For degenerative tears, you are right that initially there will be more pain when there is a partial tear, and when the tear completes, then it becomes less painful. But the disability increases once the full complete tear is over.
Okay, so
but if a full thickness tear presents in association with secondary frozen shoulder, then the pain is high.
Okay, very absolutely. The points is very, very clear. The rotator cuff patients, though there is cuff injury, though there is cuff tear, we might think that weakness would be the main presentation, but weakness is the least common presentation. Pain and stiffness are the very common presentation. So because of which these are confused with some other shoulder condition, and pain is the most common condition. And usually many of shoulder conditions has this particular entity, like night pain and pain while moving the shoulder up. These are the very specific, very common complaints with the shoulder pain, and these are common with rotor cuff tear as well. And researcher mentioned that the pain is more common with the partial tear, and weakness is more common with the full thickness tears. So many patients ask us when we diagnose them as cuff tear, what has caused this cuff tear? So Amit sir, what do you answer?
Ask what has caused this tear. So if it is a trauma, then it is a trauma has caused the tear. If it is a degenerative tear, then I will tell the patient that there are multiple factors. Could be a degeneration, just a simple degeneration. Could be a micro trauma of your rotor cuff tear. Could be various types of acromial, which is impinging. Could be a osteophyte into the greater tubercle. Could be osteophyte in the superior head of the superior tubercle of the glenoid. So for a traumatic, it's very clear this is a trauma.
Yes.
For a non-traumatic, it is multifactorial. Yes, Bibek.
Okay, sir. So reason why I ask this question is, do you ever try to search for the cause of rotor cuff tear? Once you diagnose the case is as a rotor cuff tear, do you try to see the cause, like the hooked acromion and all? Do you
Absolutely
do it always, or it's just optional?
No. I
You always do it, right, sir?
I always do it. Specifically, first I decide either it is a traumatic or it is a atraumatic. I say a degenerative, or if it is a degenerative,
Yes,
I again try to identify what has caused this treatment so that we can address that particular step.
yes, sir. So there are multiple causes of cuff tear. One of them being the, as Amit sir has mentioned in his talk, the age more than 40 is the most common cause, because as you age, the cuff quality becomes very, very weak, and the tear microtrauma may be there. And other causes are intrinsic cause within the shoulders, right? The acromion and all. So we have to always search for the cause of this repetitive microtrauma, which will cause the rotor cuff tear. Question to Arjun sir. There are many
Bibek,
yes, sir. Yes,
there is a question by Sudeep sir. If you can take this question from chat box.
chat box I cannot see. Okay, sir, I'm seeing it. How often do you get history of trauma? So, question is, how often do you get history of trauma in the work of tears? Sir, you take it, sir.
I think we it's very premature to say how much this traumatic cause, but for some reason, since we work in BNB hospital, which is basically a trauma center, we see about 50-50 of traumatic and degenerative, but this clearly depends upon the age. So older the age, degenerative becomes higher. Younger the age, the traumatic becomes higher. That is the experience of our center.
Okay, I think the answer has the question has been answered. So my next question is to Arjun sir. There are many tests, specific tests for rotor cuff, various conditions of shoulder joint pain. So what are your batteries of few sets of tests which you do in your OPDs as a general practice, as a daily practice, to diagnose a case of rotor cuff tears?
Actually, the question answer has been eased by the presentation of Dr. Amit. I also do agree that for the supraspinatus test, here I do see the job test, okay, and see the strength of the supraspinatus. You can compare with the opposite side. And if it is for the suspected infraspinatus or the complete with the supraspinatus, then the sectional rotation test and the 0 degree of abduction is the specific test. And for the subscapularis, I most of the time I do this lift off test.
Okay. So for supraspinatus, empty can or job test. For subscapularis lift up, so infraspinatus lag sign, and for teres minor.
Teres minor, and this is for the teres minor, this horn blower test.
Okay, sir. So any test you do about the impingement and all?
Yeah, I do Kennedy test. Okay, near impingement test, and sometimes I do give an injection also, and to distinguish whether it is the impingement alone or it has got tear of the rotor cuff also, supraspinatus.
So my next question is, sir, you do all of these tests in your clinic, and you diagnose the case as rotor cuff tear.
Okay.
How common you get a perfect match after MRI? Is it 50-50 or you get
less than 50, less than 50.
Okay. My question to Nabin sir, your experience with this clinical test. What is your preferred test? What are your sets of preferred and your result after MRI? Nabin sir.
Naveen, you are muted. Unmute.
I was unmuted. Yeah. Okay. Actually, the setup test already being set, the same test I do. One thing I just want to say that I also want to see the wasting of the important muscles. So I want to adequate exposure and see the supraspinatus fossa, infraspinatus fossa, where there is a wasting is there or not. And when I am doing already being said all tests that the empty can and full can, and if there's a less pain in the full can, then I also see for the impingement and come to know about there's a definite some evidence of impingement is there. Besides that, this test for infraspinatus in the adducted position, external rotation, teres minor in abduction position, and lift up test for subscapularis. And the same time, I also look for the other cause associated with that. Right? Sometimes you see pain in the acromial clavicular region, so that tenderness I want to elicit while examining the shoulder. So the tests are the same. Only thing additional point is the tenderness at the acromion point and the wasting of the important muscles I want to see.
So how common you find that your diagnosis is correct after MRI?
Many, it's not 100%, but definitely more than 50% cases my match is there with my clinical test.
So more than 50% you diagnose.
Because teres minor in my practice, very infrequently I do not get teres minor involvement there. Most of the time it is supraspinatus and infraspinatus, and these things come in MRI also. If my clinical diagnosis is this, that MRI also matches with that.
Okay, absolutely. So the message from this slide is there are many tests, there are batteries of tests. Our textbook mentioned so many tests, more than 100 tests. We do not have time to do all those tests, and we do not need to. There are few sets of tests. Amit sir has mentioned in his presentation, and Arjun sir and Navin sir has also retold them, because there are few sets of tests: speed test, jobs test for supraspinatus, lift up test for subscapularis, the Hornblower test, and lag sign for infraspinatus. These tests you have to do, and impingement test certainly for the supraspinatus. So these few tests you can do, and you can finish in within 1 minute in your busy clinic, and you can come to conclusion. And many of times we almost 50% of time we will get correct diagnosis with this clinical test. As I have already mentioned, many of these shoulder condition overlap, so there is no 100% with this clinical test. And this is also supported by literature, because these many tests, like they have compared 5 tests of subscapularis, 4 tests of infraspinatus, 5 of supraspinatus, and 2 tests of biceps, and none of these tests have good sensitivity and specificity. Some tests have good sensitivity, some have good specificity, but the conclusion is, if you combine all those tests together, you will reach to your conclusion very nicely. So the message is, do few particular tests, master them, and always do those tests in your clinic, and you will start diagnosing the cases of rotor cuff tears. So diagnosis of rotor cuff requires good history examination, investigation, and some injections. Amit sir has touched about injection test. My question to Navin sir: how often do you inject?
Injection is not very common, but most of the time whenever I use injection, that will be not just a xylocaine. It is combined with the steroid and is more of a therapeutic rather than diagnostic.
Okay, sir. Why do you inject? When do you inject?
Yeah, whenever there's a confusion between my pain and paralysis. So sometimes because of the pain, patient cannot do the action of that particular muscle, and I feel that it is because of weakness or just because of pain, patient is not able to do. So relieve that pain, I inject, and we take care of pain, and then I can assess the proper power of that muscle.
So you inject before investigation or after investigation?
It's basically before investigation. Once I make a certain first clinical diagnosis. Now, in order to when I make particular diagnosis, then at that time I assess that my clinical assessment is adequate or not. If I am fair enough with my clinical assessment, I go for investigation. If I am confused whether this or that, in those cases I inject and see let the pain relief, and then again examine.
So what is the volume of xylocaine, and what is the volume of steroid you use, and what is the brand of steroid you use when doing injection test?
See, in the test, is basically just 1 ml, 1 ml I use. But for the therapeutic purpose, like I said, many of the time it is the frozen shoulder and the rotator cuff interlinked over there. In those cases, if with the physiotherapy I am not able to correct that stiffness I have to give, in those cases I use therapeutic. So to elevate that therapeutic, my volume is more. It is more of a maybe 10 ml, 15 ml. If the frozen shoulder is associated, is there. Just for clinical test, just to relieve the pain, just 1 to 2 ml, 1 ml xylocaine and 1 ml dipomedrol I inject.
Okay, you inject methylprednisolone, right, sir?
Yes.
Okay, Amit sir, this is very important thing, the injection test. I think very underutilized. What is your take on this, sir?
If I have to use for a test purpose, like I absolutely agree with Navin. If my clinical examination is good enough to give me information I want, I do not inject. If it is not good enough, then I inject and again examine. But if I have not done radiological investigation, and if I don't know either the tear is complete or it is incomplete, what type of tear it is, I do not give steroid. So steroid is always after the thorough investigation and understanding the pathology of the rotator cuff, then only I give steroid. Before thorough investigation, if I have give to injection, then I give xylocaine 1. So I give 3 ml of xylocaine subacromial space.
So if using steroid, what is your preferred steroid, methylprednisolone or triamcinolone?
Earlier, I used to use methylprednisolone, but if you remember few literature, they say that these methylprednisolone, they crystallizes and they cause post-injection pain, not only in shoulder, in other areas also. Since then, I have changed the methylprednisolone into a triamcinolone, and I'm happy with the triamcinolone.
So is Binodai around? Binodai? Okay. Arjun sir, your take on injection test.
Yeah, BIBEK,
Common injection test.
Yeah, what I do most of the time, I do try with the non-conservative treatment with the physiotherapy and an acid before giving an injections. And injection is, I do give injection in 2 situations. One is if the patient is advised for the MRI for the investigations, and he or she denied because of the cost factor and so. And in that situation, that is both for the investigation as well as therapeutic purpose. In that situation, I do use steroid also.
Yes, sir.
And another situation is after investigation with MRI, and I do I explain to the patient about the options and prognosis, and considering the age of the patients and the interest of the choice of the patients. In selected cases, I do give injection. Otherwise, I do give the options for the surgery and so as a treatment. And so one is therapeutic, another is a diagnostic in some situations, but most of the time it is therapeutic one.
Okay, okay, thank you, sir. So the message is very clear from our faculties. Injection test we have to do. This is very underutilized test, and this will be very, very diagnostic in some situation. Never do injection test in each and every patient. Do injection test in only those patients in which the diagnosis is confusing, because as I've already mentioned, the pain, shoulder pain is very confusing. Cause of shoulder pain is very confusing and overlapping. Sometimes because of pain, patient may be having positive jobs test, that is MTCAN test, and there may be weakness on exam special test. There may be weakness of supraspinatus and even other coughs. But if you inject in the subacromial space few ml of xylocaine, that is the local anesthetic, and if you examine that patient again after 5 minutes, 10 minutes time, what happens is because of lignocaine, the pain will be gone. And if there is no tear of rotator cuff, the power will return back. That is there will be normal power. So you will be differentiating the rotator cuff tear with not rotator cuff tear conditions, and this is very important. And regarding the injection of steroid, as Amit sir has already mentioned, if there is complete rotator cuff tear and if you have planned for surgery, injecting a 1 dose of steroid will delay your surgery by almost about 3 to 4 months. So I think injecting steroids in those conditions may be very problematic. So I think if you are suspecting a case of rotator cuff tear, delay the injection of the steroid and do only after the MRI.
And BIBEK?
Yes, sir.
And again, if you have planned to do a MRI, better not give
Yes.
an injection because it can confuse with the tear also.
Okay, okay.
If you give injection and have the MRI done.
Okay.
Practically what happened, Bipenks, most of the time, whenever you see our patient population is like that, whenever you say injection, they are really afraid of that. You will say, I will inject something about there. Rather, they will say, no, Dr. Sahab, tapai aru je garnus huncha, ma MRI ne garna tayar chu, tara sui chai nalagainus. That is the common scenario. So they are able to go for investigation in spite of even just xylocaine also, they will say, no, leave it, I will go for investigation. That is why I think the diagnostic injection is less utilized in our part.
Yes, maybe, sir.
I think BIBEK, let me again emphasize what
please.
Arjun sir and NABIN is saying, that right, left, and center, we are giving steroid injection in the shoulder without knowing what pathology we are dealing with. I think the whole point, both Arjun sir, NABIN, and you and myself want to emphasize on that. First, you understand the pathology. You understand the pathology first, then you decide either you are going to give steroid or not. Rather than, without understanding what pathology is inside, do not give injection in most of the patient. That is, if I agree, if I say this, my faculty and panelists will agree or not.
Yes.
Yes, yes.
Yes. So can we conclude that injection tests are underutilized because of various reasons, as Naveen sir has mentioned, and to reach to diagnosis in certain conditions, we need to inject, but better not to inject steroid before the final diagnosis is made by imaging. And if you have to diagnose before all those investigations, inject only the local anesthetic, right, sir?
Yeah.
Yes. So do you do injection under USC guidance, any of our faculties, or is it required?
No, no.
So there has been very much fuss about the USC guided injection in shoulder. So I think literature also mentioned the blind injection at subacromial space. Even if you try to, if you are planning to inject at the shoulder joint, and if it goes into the subacromial space, the results are same. So practically subacromial space is very easy space to inject. You have to go just below and lateral to the posterior edge of acromion, and you have to direct upward and inject it. It is very easy. So USC guidance is not required.
BIBEK,
Yes, sir.
in our institute, one of the resident had done thesis on that.
Yes, sir.
In two groups of patients, one with a USC and one with without a USC, but the result was same.
Yes, sir.
There is no significant
Yes,
difference.
sir. Yes, sir.
I think
that was
Vivek,
what yes.
Vivek, can I just add? Can I just add?
Yes, sir. Please.
So over last 2.5 years, we have available ultrasound machine in our OPD. And what I have also, as Arjun sir said, that for giving high volume of injection, say 2 to 5 ml into the subacromial space, probably you don't need the ultrasound guidance. But if you are talking about very low amount of steroid and giving in certain specific area, for example, if you are giving in the biceps or the bicipital groove, त्यस्तो ठाउँमा specific area ma low amount of dose दिनु छ भने चाहिँ probably ultrasound is still a beneficial.
Okay.
Dr. Amit, I just wanted to know, is there any differences like on the volume of xylocaine given with steroid? Because the steroid, the amount of steroid can be same, but you can give either 3 ml of xylocaine or 1 ml of cyclin. Does it cause any effect on the long run?
There is one study which is published in JBJS, which has compared 1 ml, 3 ml, and 5 ml of local anesthetic. They have compared the onset of effectiveness, and then they found that in a bigger shoulder, in a European people, when the shoulder is big, and then the subacromial bursa is very thick. So if you inject into the subacromial bursa, it will localize around the bursa only. So you have to give a larger volume, and they recommend about 3 to 5 ml of subacromial injection, because if you understand, this is quite a big area, from the teres minor, then infraspinatus, supraspinatus, and the subscapularis, a big area. Probably 1 ml of xylocaine is not suffice to cover the whole large area. That
so
is
better go higher amount.
Yes, sir. Up to, they said that there is no difference between 3 to 5 and more than 5. So around 3 to 5 ml of xylocaine is good enough.
Yeah.
Okay. Thank you, sir. So why I mentioned this USC guided and all is because there is so much of fuss about doing very specific injection, doing very on-site on the under vision injection. So don't hesitate to inject because you have no USC, because the subacromial injection is very easy, and usually under the injection under guidance of USC and without the blind injection is almost same the result. So try to inject, it is very easy. So coming up to investigation, can I ask Nabin sir, how common do you do the rotator, ear rotor cuff tears, the plain x-rays?
Almost all the cases, plain X-ray is the first investigation of choice, and especially the shoulder, affected shoulder, right or left, anterior-posterior view. And if patient is very much painful or stiff there, then I don't ask for the axillary view. Otherwise, AP, axillary, and scapular outlet view. These three are common investigations for me as an investigation of this.
So do you always do other shoulder for comparison, or do you do only the same shoulder?
Only the affected.
Okay.
Only affected.
Okay. Okay. So do you ask your radiologist or radiographer to have true AP view of shoulder joint, or you get whatever the radiographer gives you?
No, I'll ask specifically. I'll ask, but I need not just the rotated film of the shoulder. I was very proper. I have to see the AP view of the shoulder where both the faces of glenoid rim should be exactly parallel, because I have to measure the other measurements in the shoulder also. So I have in the first 1 or 2 cases I have to show them exactly, and now they know. And if I write true AP, then they will get that X-ray.
Sir, if you ask me, ask us, this has been a Herculean task, and the true AP of shoulder, X-ray true AP of shoulder, to get it from the radiographer is very, very difficult. So what is your experience? I'll ask Arjun sir. He works in very busy center. True X-ray, true AP of view of shoulder joint.
No, we should send a resident to have it done. Otherwise, it is not possible.
Amit sir, your experience.
BIBEK, we work in same place, and we have seen that
Yes.
Out of 10 X-rays of shoulder, we advise true AP. Only one will get a true AP. Most of the time, this is oblique view. They only
Absolutely.
understand that true AP is putting the patient straight and shooting the beam straight. True AP is not that. So it has to be 15-degree, projected towards the outside. So maintain the scapular retroversal. So probably that is one. And I think what Nabin said is very important. You must try to teach your radiologist to do a proper X-ray. Unfortunately, in our center there are 13 odd radiographers who do this X-ray, and it's not possible to teach everyone.
Yes, sir. So this was what our faculties have been mentioning. The picture in left side is not true AP. It is a AP view of the shoulder joint, but picture in right side is the true AP view of the shoulder joint. In this AP normal AP view of the shoulder joint, you can see the glenoid, the pear-shaped glenoid. But in true AP view of the shoulder joint, what happens is the anterior and posterior margin of glenoid overlaps, and it is this film where we take all the measurements for the rotator cuff tear. So another very important film is the outlet view. It is scapular Y view, in which we see the various type of acromion, which is generally considered as the risk factor for the rotator cuff tear. So this is technical method how we get the true AP view of the shoulder joint. As we know that the scapula is rotated about 30-degree or 30 to 45-degree anteriorly from the transverse axis, coronal axis. So we have to put plate just parallel to the scapula and project the light, project the X-ray beam right perpendicular to this, or you can rotate the patient. You can ask the patient to stand, and you can rotate the patient towards the same side about 45-degree and then project straight. So this is how we get the true AP view of the shoulder joint. And if we project like this, which they normally do, and you will get the not true AP view of the shoulder joint, you will get the pear-shaped glenoid visible. So another thing why we do shoulder joint X-ray is to, as Amit sir has already mentioned, the rotator cuff arthritis, long-term rotator cuff tear will have rotator cuff arthropathy, and this is how they look like. And to make the decision making whether they are amenable to treatment or not, the X-ray will decide. So plain X-ray, there are multiple things. Amit sir has already mentioned acromiohumeral distance. This is how we take inferior margin of acromion and superior margin of humeral head. More than 12 mm means dislocation or subluxation. 8 to 12 mm is normal. 6 to 7 mm means thinning of tear of supraspinatus. Less than 6 mm means irreparable. So this is very important identification. Acromial index is another thing which we do in plain X-ray. We take superior and inferior margin, the straight line, then another line over the lateral cortex of humerus, and lateral margin of the acromion. We get this ratio. If 0.7, this is a risk factor. Another is critical shoulder angle. This is how we measure, and angle more than 35 degrees risk factor. This all critical shoulder angle increasing, and all this is because of lateral overhang of the acromion. So more lateral overhang of acromions mean more impingement of the rotor cuff and more chance of rotor cuff tear. These are various type of acromion. Amit sir and Sushil was mentioning. Hook type of tear is the risk factor for acromion, the rotor cuff tear, and we have to always search for it, because while treatment we have to treat this acromion by acromioplasty. This is rotor cuff arthropathy, in which this happens. The acetabolization of acromion will occur, and this is some other classification. So my next question is to Arjun sir. How common you ask for ultrasound in your cuff tear patients?
Previously, we had one radiologist. He was much interested in musculoskeletal ultrasonography. These days, he left it. So even though we send, they do not give a proper reporting, and they cannot give it their exact opinion. So these days, I am not sending any ultrasound for the rotor cuff pathology.
Okay, Nabin sir.
This is one of the very useful and very common investigation. If you have expert radiologist with you can do. But practically, if I said after knowing from conferences and all this has become so common, I also asked few cases. But my radiologist said, see, our ultrasound machine is like that. It cannot diagnose this. So I have to go for MRI. So almost all the time I do MRI, not ultrasound.
They got to have a special probe also, they say.
Yeah.
Amit sir, I think you differ a little, because I have seen you doing ultrasound in your patients. So your take on ultrasound?
I think I agree with both Naveen and Arjun sir that though this is very, very valuable tool, unfortunately we need still more time to utilize this to its fullest. However, we have learned how to do it, and I have been doing it very regularly in most of our patients with rotor cuff tear. But my primary for the diagnosis, it is MRI. For the follow-up, I routinely do ultrasound follow-up of these patients whom I have repaired.
Okay, so this is just a picture of how it will seen in the ultrasound. There will be one layer of skin at the top, then there will be deltoid layer, then rotor cuff tendon, and then humeral head. If there is rotor cuff tear, what happens is there will be retraction of this tendon, and this is another view where we can see the biceps tendon, and over there is the subscapulary. So the advantage of the ultrasound is you can compare with the other side always, and it is more dynamic. MRI is static. The picture is of that moment only. If USG can be done, this is very dynamic, when you can move the shoulder and see whether that tendon is moving along with the movement of shoulder or not. So, but as our three faculties have already mentioned, we are lagging in having the perfect, very good musculoskeletal ultrasonologists in Nepal. So though our country is very poor country, we still have to depend on MRI for diagnosis. Though the Western literature mentions that ultrasonography is as good as MRI, but it is more accurate, cost effective, and safer than the MRI. So when you do MRI, what do you look for, Nabin sir?
First of all, in MRI, besides this partial thickness or the full thickness tear, I also look for the quality of the muscle. If it is tear is there, then what is the what is the size of the tear? As in the coronal plane, I measure the distance, and in the sagittal plane, I meet the width of the tear. So I want to know the exact size of the tear, partial or the full thickness, and as I said, the quality of muscle. These things are common things I look for there. Whether it is repairable or not, basically my purpose is that the tear is there, it is repairable or not. So on these guidelines, I want to see about the rotator cuff.
You mentioned a very important thing, the quality of cough. So how do you assess the quality of cough with your MRI, sir?
Quality of cuff, that the fatty degeneration of the cuff, especially in the C, that the Y view, if it's still all the supraspinatus, infraspinatus, and the subscapularis basically, and that fatty infiltration, that the gotalier grading is also there. And so how much that degeneration is there in this basis, the gotalier classification is there. So this is the 1 to 4 they have classified, and some radiologists have they just classified that into mild, moderate, and severe. 0, 1 they said mild, 2, 3 as a moderate, and 4 as a severe. On that basis there. So this is you have shown the picture over here. This whitest thing is the this is the fatty degeneration. So on the grade 4 there's a too much of fat and less of a muscle, but where in the A 0 or 1 there is a more of a muscle and less of the fat. So if more of the fat is there, then that is gives a prognosticate that probably the repair might not be very useful in those cases. So we have to offer some other options.
Okay, Arjun sir, you do MRI, you get rotor cuff tears. What would you like to see? What do you see in your MRI pictures again for final decision making?
The extent of retraction.
Okay, okay.
And the quality of the muscle is Nabin mentioned.
So extent of retraction, the level of retraction is another very important thing on which we make the diagnosis and on which we make the decision on rotator cuff tear. So how do you, what is your take, sir? How you do it, retraction?
What do you mean to say?
Which classification do you follow on retraction? There are many classifications.
Is that Illman classification?
Pate classification, you can use that. Up to the footprint side, and then up to the head, and then up to the glenoid, 1, 2, 3. In that
yes, this was what I was mentioning, sir. So Pate classification, the retraction is very important. So I think Arjun sir was mentioning this, right, sir?
Yeah.
So with regards to this Pate classification, up to which stage do you advise for repair, and after which stage you don't advise for repair, sir?
Mostly stage 2.
Stage 2, right. Amit sir, your take on this?
If it is traumatic, all stages will go for repair. If it is degenerative, 1 and stage 2 definitely will go for repair. Stage 3 base depends upon so many factors. If gutalier is appropriate, if your gutalier and the hamada is appropriate, you can always try a repair based upon the age. So if it is a young patient, whatever the Pate retraction, you should always try to repair. Even if it is a partial repair, you should try to repair.
So many things have been cleared by our faculties. At first, you have to differentiate whether it is acute traumatic event or whether it is degenerative. If this is acute traumatic event, what may happen is you may have good retraction because of pull of the muscle. So what you have to do is you have to see bulk of this muscle as well, the supraspinatus. If this muscle bulk is very good, whatever retraction, as Amit sir has mentioned, will go for surgery. If this is degenerative, if gutalier 3 or more, if tangent sign is positive, what happens is there is more atrophy of the supraspinatus muscle, there is more fatty infiltration, there is more fat than muscle, then even if we repair, this muscle won't function as it should do. So in those cases, usually they are Pate 3, Pate 2 or more, mostly Pate 3. So in those cases, what we do is we do not really advise for surgery, but all the traumatic tears, whether Pate 1, 2 or 3, what we do is we advise for repair. Right, sir? Can we conclude like this?
Absolutely, BIBEK. Can you take a very interesting question raised by Dr. Rajiv Manandar in the chat box?
Okay. So question is MRI done for every patient who undergoes USC? Okay.
My answer is yes.
Navin sir.
See, for the diagnosis purpose, being our condition, the expertise of our radiologist and musculoskeletal radiologist, the first diagnosis is always MRI. It's a must to diagnose it. Subsequently, in follow-up, whether how your repair is going on, healing process, in those cases, you can conduct the subsequent ultrasound. The MRI is must.
Okay, my question to Amit sir again. Why yes, sir? Why the answer is yes?
You see, grading of Guttler grading or all this kind of thing is very difficult with the MRI, which is crucial with the ultrasound, which is crucial. I also said that I do not routinely do pre-operative for the diagnostic purpose. I do not routinely do an ultrasound. My diagnosis is basically dependent upon an MRI, but still I do an ultrasound just to have a baseline recording of that patient so that it will be beneficial for me when I do the follow-up that particular patient. So Rajiv question is absolutely right. If your ultrasound is not good enough to give you a diagnosis, not good enough to dictate you what treatment is required, what is the use of ultrasound? Are we over talking about ultrasound? I think that is what Rajiv was trying to say. My question is to BIBEK. So too much question to us. So what do you think?
Yes, sir. I think as of now, the USC is not up to mark. And even if USC is up to mark, the muscle atrophy, the retraction, all those cannot be mentioned by the ultrasound. I think MRI is still must before we undertake patient for surgery. So
maybe Rajiv has something else in mind and you want to come in and give us some opinion.
Raju sir, you can come in and please come in, sir.
No, I mean, basically, no. The thing is, basically, what I was trying to say is maybe the ultrasound has other diagnostic capabilities. No, I was thinking Vivek showed us such a lovely video of that ultrasound. So what I was thinking is, let's say if a patient, if we could make out, for example, a patient who had rotator cuff tendinitis. Now, so before the injection, if we could just do an ultrasound and find out whether there was tendinitis or maybe a very small partial tear that we would not actually need to, actually assess by using MRI. So maybe there would be a value of that ultrasound, which you showed beautifully, that attachment. That thought came to my mind. That's why actually I made that chat comment in the chat box.
Okay, that is very thoughtful and absolutely right. If some other like partial tears can be diagnosed with the USC, the MRI could have been avoided.
Yes, because with that beautiful view, I mean, you could spend around 10,000-15,000 of the patient, no? Because ultrasound hardly costs anything.
Yes,
so
yes,
that's what came to my mind. Yeah, that's why I made that comment. Thanks.
Amit sir, how common do you follow this tangent sign in air MRI? Do you follow Guttler or tangent sign, or you follow both?
Sorry, the current literature say that tangent sign is more, more important, but I still follow the Guttler classification or Guttler infiltration rate.
Okay. Arjun sir?
Guttler.
Okay. So I think both Guttler and tangent sign are very important marker for muscle atrophy, muscle weakness, the fatty infiltration. Guttler is more for fatty infiltration than muscle atrophy. So, but tangent sign is very easy. You get the Y scapular Y part of that MRI and just make the tangent over this. And if your muscle lies below this tangent line, then this rotator cuff tear is not repairable. This because all of these tears will be Guttler 3 or more. So this is very easy and very easy to learn. This is Guttler is a little difficult one, and radiologists usually do this classification for us. Yes, sir.
BIBEK, can you go to the previous slide? Yes, tangent sign is very good for assessment of the supraspinatus one. But if you see Guttler is not only limited to the supraspinatus. If you see in this X-ray also, this MRI cuts also in Guttler 3, 4, you can assess the supraspinatus, the infraspinatus also. Whereas tangent sign is only specific for supraspinatus.
Absolutely, yes, sir. But for supraspinatus, you can easily assess with the tangent sign. And for beginners, I think tangent sign is as good as good till here, right, sir?
Correct.
Okay. So this is another thing which we have mentioned, the bulk of the rotator cuff, that is supraspinatus or infraspinatus, which we have to see. If bulk are okay, whatever retraction, you can go for surgery. The role of CT and CT arthrography. So Arjun sir, how common do you do CT in your rotator cuff patients?
Not in rotor cuff tear, only in instability.
So you have never done CT for your rotator cuff?
Yeah.
Okay. Any indication you could think of, because I got some while searching the literature.
No, I'm not aware of it.
Okay, Navin sir, how common you do CT scan, CT arthrography, or only MRI?
Advantage of MRI is so much so nowadays the CT arthrography is replaced by MRI in all of my cases.
So this is just for completion purpose. So MRI is the gold standard. MRI, the CT can be done only when MRI is contraindicated, like the metal clips are there, the pacemakers are there, metallic pacemakers are there. The MRI is contraindicated, you can do CT. And those, the claustrophobic patients.
But Vivek,
Yes, sir.
but Vivek, these days radiologists have stopped doing this arthrography, and so even though you ask these investigations, they may not be able to give you a proper reporting also. And so that
That is there, that is there. But for theoretical purpose, if MRI is not possible to do, then what else? The CT or CT arthrography can be done, right, sir?
Okay.
Nowadays, this metal artifact subtraction MRI is also available. If your implant is not in humerus or in clavicle, somewhere else, they can very easily do MRI also.
No, we are not worried absolutely with our metal implants of our bone fixation, sir. But we are worried about some clips, the aneurysm clips that may be metallic. The other surgeries like pacemakers that may be metallic, and our MRI may do problem with the rhythm of heart, and this is where there is absolute contraindication of MRIs. The metallic implants used for fixation of fractures are not so much considered as contraindication these days. I think these
I
are
think
real.
Vivek, I think you have a lot of slides, and probably in Nepal, I say that probably CT arthro is not useful. Not only because it is an invasive procedure, it requires some dyes and all, but you need to put your injection right into the joint. Most of the time, this is radiologists cannot do that, and then radiologists have lesser experience with the reading of CT arthro, so that is why the reports comes very weird, and it will not give us an idea of the fatty infiltration. It will not give us idea about other things also. So probably CT arthro will just tell us what are the tendon that has been torn, how much is the retraction, and probably only in cases where you do need to do it. I think CT arthro is not very important investigation, as Navin said, that not very important in the era of MRI.
Yes, sir. So what will you do in those patients, the absolute contraindication we just mentioned?
I'll do an ultrasound.
Okay.
I will do an ultrasound. So radiologist better reports ultrasound than the CT arthro.
Okay, points well taken. Thank you, sir. So decision making in shoulder injuries, shoulder rotator cuff tears is very difficult. As Amit sir has already mentioned, I think we have this will be our last slide, and we'll wrap up. So there are many studies in which they have studied the natural history of the shoulder joint. As this is the same repetition from Amit sir's slide. As you age, the rotator cuff tear increases, and many of these shoulder joints are asymptomatic. This is study where they have studied symptomatic and asymptomatic rotator cuff tears. More than 60 years, almost 28% of partial tears are asymptomatic, and 26% of them are full thickness tear and they are still asymptomatic. How common is this scenario in your practice? Amit sir, I'll start with you.
Bibek, you raised a very important question. Unfortunately, asymptomatic patients, they do not come to us. They remain at home. So these many of these patient asymptomatic were done on cadavers, and all those kinds. So asymptomatic patient, they usually do not come to us until unless you do a population-based study. So in my practice, I do not have a asymptomatic rotor cuff tear. All patients who come with some problem, and then I investigate and diagnose, most of them are symptomatic.
Okay, you get what is your percentage, partial tear and complete tear? You see lots of shoulder patient. What is your percentage if you make that division?
I think it's 50-50, Vivek. It's
Yes,
50-50 partial, but partial tear patients are more, symptomatic. They have more exaggerated symptoms. They have more pain, especially if it is a bursal side partial tear. They have more pain compared to the full thickness. The full thickness tear have more of a stiffness. The partial thickness tear, they have more of a pain symptoms.
absolutely. So partial tear patients are the patients with partial tears are very high, and number of them, I think it's 50-50 as Amit sir has just mentioned. So, and these partial tear patients are more troublesome because pain is their main symptoms, and whatever you do, pain does not go away. And if there is complete rotor cuff tear, we can show that their cuff has torn and it needs to be repaired. We can advise for surgery, but partial tears are very problematic. So how do you tackle these partial tear patients? How will you approach, sir? How do you do, Amit sir?
Okay, so I have a straightforward, protocol for partial tear. All partial tear, grade 1, 2, 3, will undergo a 6 weeks of rehab at least. If the patient do not do good with 6 weeks of rehab, I supplement with subacromial steroid injection and another 6 to 8 weeks of rehab. So only those patients who have grade 3, that means more than 50% of tear on the articular side, more than 30% tear on the bursal side, and they are not responding to a good conservative treatment, will only qualify for surgical treatment.
Okay. Arjun sir, your take on partial tear.
Yeah, I also start with the conservative treatment, pain management, and physiotherapy program. And if the patient persists pain despite that, then I do give a steroid depending upon whether it is on the bursal side or the articular side. Bursal side is, with mention, it is always very much painful. And if it is not responding with that, and then even I do wait for 3 to 6 months also and see the response. If it persists like that, then only go for other options, alternative surgery.
Okay, so the natural history studies have shown that up to about 40%, up to about 40%, half of these patients the size may increase in next 2 to 3 years time if the patient with this conservative management, if they are improved. So what is your protocol? You ask them to visit you again and again for follow-up, and you do MRI, repeat MRI in their follow-up studies, follow-up examination, or you just do the clinical examination? Amit sir.
I think one thing I just would like to add, that if your partial thickness tear, location of the partial thickness tear is also important. If it is more towards the anterior, so adjacent to the subscap, adjacent to the coma tissue, then most of these anterior tears have a high propensity of progression. So I consider them, after failure of conservative treatment, I'm little comparatively more aggressive. But if it is a posterior tear, I will still defer from surgery, and then literature also have shown that the outcome of partial rotator cuff tear are not very that clearly mentioned. Advantage of surgery. Did I answer, Bibek, your question, or you were asking something?
Yes, sir. My question is first part of question has been answered. Second part, sir, if patient increase with conservative, will you ask for the follow-up visits? If yes, how frequently? And what will you do in follow-up visits? You do repeat MRI, repeat your ultrasound, or only clinical examination?
You see, first, I'll see the patient in 6 weeks time, how he's improving. If he's improving, I'll see in 3 months, 6 months time. And then initial, I will depend upon his improvement in the symptomatology. So if the patient is improving from his symptom, there is less pain, increased range of motion, I do not do an MRI. But if there is a sudden change in pain, sudden change in my clinical examination, weakness has increased, something has gone, dramatically wrong over past few, between this follow-up, then I will get an MRI done, if not ultrasound.
Okay, thanks, sir. So last question to Nabin, sir. There are some full thickness tear. We expect that if there is full thickness tear, patient won't be able to move his shoulder. That is, the patient won't be able to do the overhead activities, the abduct the shoulder. But there are some conditions where, despite full thickness of rotator cuff tear, patient will be the range of motion will be fairly normal, and patient presents to you for pain and some stiffness. So how will you tackle these patients, this particular set of patients? You see full thickness tear in MRI, and many of these full thickness tear progresses by the literature. So how will you tackle those patients?
See, in the full thickness cases, first is the traumatic and non-traumatic. Traumatic, all the cases I go for surgery. In these degenerative cases, most of these full thickness tear are usually older age group, where they are more of an elderly age group. This problem is there. So at that time, I see the clinically patients, assess thoroughly what is the main problem over there, and I talk with the patient. See, you are having
patient has some pain and some stiffness, but range of motion is fairly okay. But you see in MRI full thickness tear. So how will you approach those patients? We do see lots of patients with such type of case scenario, right, sir?
Yeah. So to take care of his main problem is pain and stiffness. So I'll treat those pain and stiffness, and I also talk with the patient at the same time. See, this is the treatment modality I am giving you. At this time now you are having a cuff tear in a way that I can repair, but subsequently maybe if you do not undergo surgery, at the chance, as you said, 2 to 3 year increase in size is 50%. So later on you might have that type of tear which I may not be able to repair. So this is the condition now. You are not having the problem of power, you are just having pain and stiffness. What do you want? If you just want pain and stiffness, then I can treat conservatively with the maybe sort of, if they deny for surgery, with a sort of a steroid, and just take care of his problem, pain and stiffness. But
I think Bibek's question is very valid, and Nabin is, Nabin's opinion is very good. But my confusion is, suppose someone comes with the partial tear, he is relatively less symptomatic, but his wasting or the fatty infiltration is less. So in an attempt to manage conservatively, and then after you follow him after 1 year, and you find out that there is a patient has worsened, or your tear has increased, and at the same time at the end of 1 year there is a fatty gutelier infiltration has also increased, and now it is grade 3, so you will not be able to repair it. So there is a two-way sword. How you tackle, Nabin, actually it is very important for all the clinician to identify this two-way. This either way, if you over delay, then there is a fatty infiltration is going on. If you are too early, then probably you are overkilling your rotor cuff. How you decide actually? That is.
So that is the way you have to talk with the patient and also his problem. And patients should know everything. As we in ACL cases also, similarly, if the tear is there, patient doesn't have any feature, then also we show. See, at present you are not having problem. In the future you might have that. In that point, so we have to talk with the patient. So your problem is now this. if you can go under this treatment. But if you leave as such now, subsequently the condition may be that I cannot repair your cuff. So you have to decide. And majority of the patient, if younger patient, I tend to go for repair in those cases.
Okay.
I think
Okay.
if I can quote unquote mention one of the very pioneer of rotor cuff surgeon, he said that don't treat your MRI, treat your patient. If your patient is symptomatic, offer him treatment. If the patient is asymptomatic with whatever size of the your tear, so why you want to repair it? That means you are treating the MRI. So that is a message I have got. And probably if you think it real wisely, the size of the rotator cuff doesn't match with the disability. The size of atrophy doesn't match with the disability of the patient. So probably it makes a point that depend upon the various factors. Age is one of them, and basically it is the symptom. If the patient is asymptomatic with the whatever size tear, I think we can wait and plan. Keep the patient in follow-up. You can wait for surgical intervention. Yeah,
So, yes, sir. A question back to you, Amit sir. You have also mentioned previously that waiting for not treating with surgical management and letting patient to have good layer 4 or good layer 3 from good layer 1. Is it justice to the patient then?
See, BIBEK, somehow what we have to understand, I don't know why you are putting that picture, but I would just talk about that arthroscopic picture. That my teacher Steve Burkhardt has brought up this concept of rotor cable and the rotor crescent. So if a tear, whatever size of the tear it may be, but if it is in the rotator crescent and has not damaged the rotator cable, the retraction will not be much. If retraction is not much, the fatty infiltration will not occur. The supraspinatus, all the muscle will fire through the rotator cable. So if your tear has not crossed your rotator cable, probably you are safe in instituting conservative treatment based upon the symptom. But if your rotator cable is torn, that means the patient will have a pseudo paralysis. If the rotator cable is torn, then there is a very high risk of patient having what you are saying, fatty infiltration. Probably in those cases, you will go ahead with the surgery. And again, reiterate, the anterior tears are very prone for progression. The posterior tears, which is near the supra and the infraspinatus, in that region, are relatively less progressive tears.
So can we make, yes sir, can we make the consensus that if the patient is asymptomatic, whatever the size of tear, never treat MRI, do not treat MRI, but keep patient in close follow-up, and if needed, do MRI, repeat MRIs in future, and if there is any sign of progression, if any sign of fatty infiltration, and do accordingly. Can we conclude like this, sir?
Yes.
Correct.
Yes. So this picture I have brought up here in purpose because as Amit sir has mentioned, Dr. Steve Burkhardt had given this concept, and he gave a concept of rotor crescent and cable, and whatever may be the size of tear, if that tear is within the crescent part, patient will be asymptomatic because the anterior and posterior attachment of, if the anterior and posterior attachment of cable is intact, patient will have a good function of rotor cuff because rotor cuff will be attached here. And so there are some patients, not some patients, there are many patients where you see rotor cuff, the full thickness rotor cuff tear in MRI, but the patient will be, the range of motion will be fairly present in those patients. So I think we have very much good discussion in today's panel discussion. I would like to thank all my respected faculties to spare some time for us. And I would like to thank Arthroscopy Society of Nepal to give opportunity to BNB Hospital, AKB Center to organize this webinar. Thank you so much.
Okay, thank you. Thank you, everyone.
Thank you, sir.
Thank you everyone.
So I think, can we ask sir to have the final remarks, sir? Ishwar sir. Ishwar sir.
Yeah, yes, Bibek, thank you. I think that was a very elaborate discussion on rotator cuff, the decision making and when to operate, when not to operate, and how to prevent. I think this was as the topic said, it was decision making. The second important part on what happens when you repair, whether it will unite or not, what is the right patient to operate, and the techniques that are more prevalent that will lead to more healing of your rotator cuff is a different section. Probably we can discuss that at another setting. Well, without taking more undue time, I thank all the participants, starting from the speakers as well as the panelists, and of course the people who are patiently, hearing with us. Thank you for attending. I hope a lot of things was learned. And with this, I think we should close down, and we will wait for the next bi-monthly masterclass. Thank you all.
Okay, thank you. Thank you.
Thank you, everyone. Stay safe. Hopefully, Corona will not return again. Bye-bye.